Good morning, everybody. To start off, I'd like to thank Vikas and his entire group for this kind invitation, and also congratulate the organizing committee for holding this conference on such an important aspect of oncology. To start off, I actually thank Naveen for setting the stage for mucositis. I was asked to cover a little bit of radiation mucositis, because especially oral mucositis, because this is part and parcel of the therapy that we give all our patients. So as we are progressing in oncology and almost 75% of our patients presenting to us in advanced stages of disease, most patients receive a combined modality treatment, and herein comes the expertise of the oncology and the entire team to decide and to actually optimally choose between the most optimum treatment regime, looking at its activity as well as its safety. And it is an important trade-off between the risk and the benefit when we look at both toxicity as well as tumor control. Now, when there are two different modalities available, it's of course important for us that we choose the one that has the maximum probability of cure. But when there are two different modalities or treatment regimes that offer equal outcomes, I think the one that offers better quality of life with organ function preservation and good cosmetic results needs to be chosen. Now, when we come and talk about head and neck cancers, and especially radiation oncology, there are a gamut of acute and late effects that we come across. I'll be discussing in short mucositis and acute xerostomia that we see during head and neck radiation therapy, and of course xerostomia as a late toxicity of head and neck radiotherapy. There are various tools and scoring systems that have been proposed to actually evaluate these patients, but what is important to understand and to also keep in mind is the fact that we need to evaluate these patients regularly through the course of radiotherapy, use pragmatic and easy to implement tools to record these toxicities during therapy, starting pre-therapy and of course continuing afterwards also, and do only the relevant necessary investigations that are necessary to take them through therapy without interruptions. Now, we all understand that there is a lot of toxicity that accompanies all these multimodality treatments, and the study by Trotti actually looks at multiple studies which have employed various treatments in combination with radiotherapy for head and neck cancers, and what is very apparent is the fact that as you intensify treatment protocols with just concomitant radiotherapy or even conventional radiotherapy alone to altered fractionation radiotherapy or combining chemoradiotherapy, there is definitely an increase in the toxicity also that accompanies these treatments. It may be as high as the oral pain would be as high as 70%. So what we need to keep in mind is the fact that as we intensify our treatment protocols, the intensity as well as the need for supportive care is also enhanced during these treatment protocols. This is another graph showing the same thing, that as we embark on many more multimodality treatment schedules, there is a tendency for increasing toxicity. So we have to preempt this, anticipate, and accordingly treat our patients. Now, what is the impact of all these treatment interruptions that may occur during treatment? What studies have shown is that there may be a loss per day of almost about 0.9 gray for a day of interruption, which means that we may have to enhance therapy by this much, or the probability of local control can also go down for a missed day of therapy by about 0.7 to 1.4%, and also with a week's gap during treatment, the fall in locoregional control may be to a magnitude of about 14 to 20%. Now, these are important facts to keep in mind when we are taking our patients through therapy. Of course, what we also need to understand that there are certain parameters that predispose our patients to these toxicities, especially the late toxicity. So the extremes of age, in our condition, of course, in head neck, it would be the older age, advanced T-stage, laryngopharyngeal tumors, where the primary, these were the strong independent risk factors. And of course, neck dissection after concurrent chemoradiotherapy was also associated with an increased risk of these complications. So what would be the general approach to any patient on radiotherapy for the head and neck region? Identify the problem, assess its severity, the structures and processes involved in this process, and the risk factors. prevent wherever possible. So embark on important and easy to use prophylactic regimes, hygiene as well as exercises, preempt, and this can be done by regular assessments on treatment as well as at follow-up, protect, which means simply as a radiation oncologist, it calls on me to be able to respect the tolerance of the adjacent normal structures, optimize the dose to these structures during the radiotherapy planning, treat whatever can be corrected and also the sequelae, maintain, which calls for persistence of care even after completion of treatment. So coming to mucositis per se, I've talked a little bit about the magnitude of the problem. As we intensify our treatment schedules, it's quite apparent that the incidence of this problem as well as the magnitude of this problem goes up from plain conventional radiotherapy to altered fractionation radiotherapy and concurrent chemoradiotherapy. And this is again apparent across several studies. The other important thing to understand is as our techniques have evolved, so also has the rate of mucositis fallen, which simply talks about it being favorable to be able to do more advanced techniques in most of our patients. The other important aspect of mucositis is that we have to be able to understand when would we begin to see mucositis in our patients. This again is a function of the kind of radiotherapy schedule that we use, whether it's a conventional radiotherapy, that is we're giving 5 fractions per week with standard doses, or are we treating them more intensely with 6 fractions. Again, the timing as well as the duration of mucositis and the intensity would be very different. And of course, whether we're giving chemotherapy alone, it would come and go. But what happens with radiotherapy is that it begins to peak at about 2 to 3 weeks, then kind of increases till the end of therapy before it tapers off after conclusion. The other risk factors are, of course, as I've said, extremes of rage. We've understood the impact of nutrition in this patient, poor orodental hygiene, neutrophil counts, other non-cancer adjuvant treatments, and of course, continued smoking and alcohol consumption are important issues that we have to keep in mind. The treatment, radiation-related, the other factors that we have to talk about is the dose per fraction, the volume that we are radiating, the overall treatment time and the technique of radiotherapy, chemotherapy issues relating to the drugs, whether it's a bolus or a continuous infusion, the type of drug, and of course, whether it's concurrent or sequential chemotherapy. Various assessment scales have actually been described. This is one of them, and this helps us to grade the intensity and severity of mucositis and also guide our treatment. And of course, the impact of mucositis would be on all aspects of therapy, not only for the patient, but also to the caregivers. And these are the updated mask guidelines, 2019 guidelines about the general measures. We do understand various aspects because this is what we really practice in routine care. But what I'd like to draw your attention to is that dental care is very important. Prophylaxis is important when we set about doing radiotherapy in these patients. Saline rinses are harmless, but randomized evidence does tell us that it would be best to use a soda salt or a bicarbonate rinse, but it should be avoided in children who may find it distasteful. Another common habit that we see in practice is the use of chlorhexidine. There is actually no evidence to support the use of chlorhexidine in radiation-induced oral mucositis. Various other mouthwashes have also been evaluated. And what we need to keep in mind is certain other anti-inflammatory mouthwashes like benzodiazepine, which we use. The impact of this essentially is the fact that they also have a local anesthetic anti-inflammatory effect and can be used. However, there are no definite guidelines supporting the use of benzodiazepine mouthwashes in radiation-induced oral mucositis. What about other regimes like use of low-level laser therapy? Again, we've heard from Dr. Naveen a little bit about this. Again, there was no guideline possible in the radiochemotherapy or the concurrent chemoradiotherapy setting for the radical setting. Now, various other agents have also been described, and there is equivocal evidence to actually support. And hence, it's not surprising to find that we really do not have any concrete guidelines supporting or not supporting the use of these agents in the treatment of radiation-induced oral mucositis. Now, various specific interventions have also been described by Dr. Naveen, and these include various pharmacologic agents like palifermin, amifostin, growth factors and cytokines, definitely not for use in oral mucositis. As a radiation oncologist, I'd like to draw your attention to the fact that today it is possible for us to modulate the radiotherapy in such a way that we can reduce the doses to the uninvolved oral mucosa. Another important aspect is the diet, what to do and what not to do. We've heard a lot about this in the morning. Now, as a radiation oncologist, what I'd like to tell the audience is that today it is possible for us to modulate the radiotherapy in such a way that we can reduce the dose to the uninvolved oral mucosa. And what this simply means is that because there is a reduce in the percentage of the mucosa that receives high doses, it is then subsequently possible for us to also look at the sequential effect of reducing these doses. So we used to once upon a time treat these large volumes of radiotherapy. Now what happened over time was we were able to reduce, and today we can do something like this, which simply means that we can definitely save the uninvolved mucosa. And this simply means that if you can reduce all this, we can definitely reduce the incidence of PEG dupe dependence as well as enteral feeding in these patients. And this is a very important sequelae of radiotherapy. The other impact of mucositis is, of course, that these patients may end up having a lot of hospitalization as well as breaks during treatment. I've also discussed a little bit about this. And the other thing is, of course, the economic impact of mucositis. This is something that we need to keep in mind because in our population, this means enhanced need for pain management, liquid diet, tube placement as and when necessary, management of secondary infections and hospitalizations, all this together actually adding to the cost of therapy. Now, what we have for radiation-induced oral mucositis is a lot of equivocal evidence, but a scarcity of practical solutions. At the TMH, what we do is good oral hygiene protocol and dental prophylaxis, removal of separable prosthetics, 3D CRT and IMRT wherever possible, use of soda salt mouthwashes, attention to nutrition and fluid intake. Local treatment, again, can be used as and when the patient needs it and can afford it. Local anesthetics are sometimes used for relief. Then systemic agents like analgesics definitely need to be used, and depending upon the pain, we need to escalate this. And for severe mucositis, we reserve corticosteroid used only for severe mucositis and also antifungals. When there is, we do not use it as prophylaxis. Now coming to radiation-induced xerostomia. We all understand that again, xerostomia is part and parcel of head neck radiotherapy. What we understand is that the bottom line is that majority of patients treated with the older techniques would end up actually having permanent xerostomia. And this is actually associated with a lot of oral discomfort, dental caries, infection, speech and swallowing difficulty, and weight loss. Now, if we look at what happens to the parotid gland function based on the doses that the gland receives, what we understand is that parotid-sparing radiotherapy has significant influence on the salivary flow, and patients receiving less than mean doses of 35 gray have better salivary flow, which simply means that we have to be able to reduce the doses to the salivary glands as and when feasible. Again, there are various toxicity scoring systems for xerostomia. This is one of the common ones that is used across the radiation oncology fraternity, the RTOG grading system. And again, like mucositis, xerostomia affects practically all aspects of the patient's life, starting from having a painful mucosa to impaired mastication, alterations in speech and swallowing, and all this probably leading to altered diet with malnutrition. And this is a continuous saga, so we cannot forget with inception of treatment and conclusion of treatment, the care continues even after completion of treatment. Now coming to management of xerostomia, what it entails is trying to prevent xerostomia firstly. Now, how can we do this? We have to look at all the other things also that go into the care of xerostomia, that is dental prophylaxis, certain stimulants may be used, but this again is query. Use of radioprotectors like amifostin, again this is really a contentious topic today, we do not use it. Salivary gland transfers have been tried, especially the submandibular gland transfer, but of course today the emphasis is on better radiotherapy techniques. And what about the other treatment of overt xerostomia and its consequences? Again, here silagogues have been used, salivary substitutes, fluoride-containing agents to prevent dental caries. Now, just quickly go to the fact that today what is possible is that today we can use. Now, this is a meta-analysis actually looking at various other forms, that is pharmacological agents that can actually reduce xerostomia, but again today questionable application in the era of IMRT and IGRT. We have our own data that looked at improving radiotherapy techniques, and what we realized was that IMRT significantly reduces the incidence and severity of xerostomia in patients with head neck squamous carcinoma. Both acute as well as late xerostomia could be reduced. This is another study that we did in our setup, and this not only reduces the grade of xerostomia in the follow-up period, but also has an impact on the weight loss post-treatment. And this is what we can achieve with the use of IMRT, better shaping of our radiotherapy. And this is a systematic review, again done from our institute, which clearly, I'll just finish, clearly proves the fact that xerostomia that can be prevented by the use of superior radiotherapy techniques. I'd just like to conclude by saying that it's not only parotid saving that is important, but we also need to look at other structures in the oral cavity, like the submandibular glands, the minor salivary glands, the sublingual glands, because these are structures that are important for the resting feeling of wetness in the mouth. So these are other structures that have to be paid attention to. And I'd like to conclude by saying that optimal patient selection is mandatory for success of aggressive treatment protocols. More attention and awareness, toxicity documentation is essential. Strategies for possible toxicity reduction include prevention and prophylactic measures, attention to supportive care, optimal radiotherapy techniques, doses, and fractionation, avoid unplanned treatments for the ultimate outcome, and of course, pay attention to patient-related outcomes and quality of life issues. Thank you.